this field. She is a member of numerous oncology associations and groups, and she will be doing an update on the current NANT trials that are currently going on. Dr. Araz Marachelian.
Made it. I was only here today and it's been really fascinating, so I hope you've really enjoyed it. I'll try to be brief because I know we are starting to get late, but I'm hoping to go through the NANT trials just so you know what's available, where we, and a little bit of maybe hints of where we're going to go. I'm going to mention briefly two other trials that were not mentioned, which are the PET-CITN trials, because they're open and relevant and slightly associated with NANT as well. So first of all, what is NANT? Lots of terms, a lot of people hear, but mainly the NANT consortium was funded quite a few years ago, in 1999, I believe. It mainly was to discover major mechanisms of resistance in high-risk neuroblastoma. How do you do that? You get a bunch of investigators all together to work together. So there are actually preclinical laboratories that are really focused on neuroblastoma that are all working together from 7 institutions, and you can see their names. And the idea of NANT is to translate what's happening in the lab to the clinic as quickly as possible, that's where NANT comes in. And we're the clinical translational arm for the work. So the bench to bedside to be quick, that's the goal. As you've seen in a lot of other slides, you know, there are consortia. Each consortium has a number of institutions. This is really a style in terms of deciding who should be involved and how do we give access to patients to these trials. NANT's approach has been to, because it focuses on relapse refractory neuroblastoma, has been to choose sites that have a high neuroblastoma patient population, because once you get to the part where you're looking at relapse refractory patients, then you're getting into a smaller number of sites that really have the volume of patients to be able to enroll enough on a clinical trial to be worthwhile. Because as you know, clinical trials are all expensive, and part of the expense of the world is also getting each trial up and going. So we've tried to have a geographic diversity. You can look this on the NANT website. And we have now been collaborating with a few countries outside of the United States. Initially it was just Canada, and now we have a few more collaborations in Europe, so that we can take sites and drugs that are new and potentially be able to study them on both sides of the Atlantic. So, what's the approach? Everyone's approach is probably a little bit different, but today what I'm going to do is talk about some of the big ways we approach neuroblastoma. So some of what got touched upon in the prior talk is looking at molecular vulnerability of neuroblastoma. So in this case, I'm going to give the example of ALK as a molecular vulnerability, but in general, that is one way, right? If you know you have a mutation, and what is that mutation? Can you go after it? And can we do something about that molecular vulnerability? Now, we all know immunotherapy works in neuroblastoma, but can we make immunotherapy better? So we are spending some time in enhancing immunotherapy. And we also know that I-131-MIBG is has response in neuroblastoma, and really also looking at, can we improve that as well by adding other agents to it? Of course, in all this, we're still trying to understand neuroblastoma biology so that we can inform new trials. So bench to bedside, bedside to bench, collaborating with our oncologists who know their patients best, and so we're not necessarily saying you need to do this trial versus that trial, but really having an option of trials that make sense for the patient. So I'll talk about ALK first, and just as an idea of a trial. And so here we have the NANT 2015-02, which is our lorlatinib study. This study, so to back up, ALK mutations are known to be present in about, depending on who you ask, so somewhere between 9 to 14% of patients with neuroblastoma. And so it's a therapeutic vulnerability, meaning you have a mutation, if you can target it, beautiful, then perhaps you can kill the tumor cell. And so many of you perhaps have heard about crizotinib, which is the ALK inhibitor that was studied in solid tumors and neuroblastoma specifically prior. And there was work that was done in the Mosé lab and Maris lab at Children's Hospital Philadelphia on this compound lorlatinib, which is an improved ALK inhibitor. And it has CNS penetration, so that's one of the things that we struggle with with penetration into the brain. And so this was an agent that was, because in the laboratory was very exciting, we decided to embark on a trial in pediatrics. So as everyone has talked about, the design of the study, you can see the schema, is we went up dose levels. Part of the reason there are quite a few dose levels on that on the left is because it was not toxic, so we went further, much higher than the adult dosing. This is a drug that's been used in adults, and we knew the toxicities there. Once we did that, we also then did concurrently, actually, some work in the adult neuroblastoma space, where there's a little more patients with ALK mutations. And then in the last part of the study, we have done a combination with chemotherapy so that we can really understand lorlatinib and how you can mix it with chemotherapy, because our head is towards the future as well for our patients who may be diagnosed today with neuroblastoma with an ALK mutation. So I'm just going to give you just a tiny bit of the tidbits. Some of this was already presented at ASCO, and a publication will come out, so be on the lookout. We are working on it very nicely, so I'm not going to give you all the beautiful plots of that publication, because next year I'll be coming back for that. Or you can get the paper. But mainly, the first thing is everyone asks, okay, well, it's a new drug. What about toxicities? What was it like? All the toxicities of lorlatinib were opposite of what you would expect from chemotherapy, which we sort of knew, but it was gratifying to see. Weight gain. In fact, our kids came off their NG tubes, which was very odd. And they were eating lots of pizza in clinic, which was very unusual. And high cholesterol and triglycerides. This is really mechanistically driven, but only the adults really had to do many adjustments for that. And some fluid retention, again, much more common in adults. Because it goes into the CNS, there are some neurocognitive effects known in adults. We had already known about this. In fact, the study has a lot of detail of how we have been studying this in young kids, because it's very different. And interestingly, you can again see this in the adults. You can see memory impairment. Some memory impairment, it's reversible. The minute you stop the lorlatinib, in a couple days, it just comes back. It's just like a little bit of fogginess and some loss of concentration. We have not seen much severe level of that. We have done lots of studies in the pediatrics space, so there are probably some, but not to the same extent. We don't understand why it's different between the pediatrics and adults. But there is some neuropsychological sort of other issues like agitation, anxiety, hallucination, or mania. Again, really in the adult space rather than pediatrics, but some hints of it in the pediatrics. Of course, it's a little hard with our little toddlers who are getting a little angry. Is it the lorlatinib? Is it the Accutane before? Our favorite drugs. So this is a side effect profile, actually pretty tolerable and doable. And then the rest of it, obviously we had good pharmacokinetics. We knew we were hitting the levels we needed to. So, okay, so what about response? Very interesting. So you can see there's complete response and partial response, and we have this thing called complete response, partial response, and minor response. Minor response is really actually a really good response, but our criteria are extremely, extremely strict about certain lesions have to shrink a certain way. So you can get an MIBG completely be negative from 24, but if your CT that was 1 centimeter didn't shrink down to 7 millimeter, then you'd be considered a minor response. So there are some of that you have to consider in there. But what I take away from this is you can see those numbers. What I take away from it is definitely the response rate was phenomenal in the adults. And in pediatrics was less so, but still quite great because these are relapse refractory, very heavily pretreated patients. And in the chemo combo in pediatrics, we saw that improve. The interesting parts are that the responses were there regardless of ALK mutation, so this wasn't driven necessarily with which ALK mutation you came in. The patients with NMIC amplification are still a little bit of and an ALK mutation are still a little bit of a challenge, and we still need to understand more and learn how to treat them. Definitely, we have seen some tumor heterogeneity in some patients where we can see some sites responding while other sites not responding, and therefore we know that neuroblastoma is heterogeneous, right? It's not just one type of disease, and this is something that we are studying quite a lot of and looking at the blood markers and the tumor markers that was just mentioned earlier about tumor heterogeneity. So doing genomic studies on the blood so that we can see these changes rather than genomic studies on one tumor site, because that is ultimately not going to give us all the answers. So we're doing a lot of work right now on all the data on these patients and looking at their genomic landscape, and that's how that's changing. And like I said, we'll come back for that presentation because it's really fascinating, back to the lab and doing some of the tracking of this resistance. But what's really exciting is this is the data that was used to now change ANBL 1531, which is the upfront study, which you may have already heard about, where we added lorlatinib to the upfront patients. The next phase of therapy is really looking at what other novel combinations we can do with lorlatinib plus. We know it works. The question is, can we make it work perfectly? And that's where we'd like to get to. We have some room to go, but this is why the lab is still investigating, and we'll be coming back with potentially new trials in that space. I'm not going to talk about NMIC today because currently we don't have an active NMIC directed trial. We have had them on and off, and you will probably by next year hear another one. So what I'm going to now talk about is an immunotherapy trials. What are we doing there right now? So we know dinutuximab is helpful in neuroblastoma, and we know that the way antibodies kill tumor is that you need the antibody plus you need your own immune cells. You can't do one without the other. And so there was actually preclinical data that was generated by Bob Seeger as well as Dean Lee, looking at activated NK cells and combining them with dinutuximab. So if you have your own natural killer cells, they're supposed to go around in your body, do their thing, but if you activate them and you give higher numbers, potentially would make your immunotherapy work better. So there's a trial that's almost complete, that's called NANT 1301 that I am leading, that is taking patients' blood, then sending it to actually the Lee lab in Nationwide and growing those NK cells, taking them apart, agitating them, helping them grow, and then giving it back to the patient together with dinutuximab. So this is the schema where you're, growing the NK cells, and back to Dr. Kushner's question, it takes about 14 days to grow the cells, and then you give it back following the dinutuximab. So we've learned a lot about how to do this. It was a cellular therapy trial in neuroblastoma in an academic setting, so very exciting. But clearly, one of our issues currently is that our neuroblastoma patients have NK cells, but they start low. And we've done this over and over again. We were hoping we can get up to 12 courses of therapy. You and I and many other actually cancer patients seem to get enough, but we've in the 14-day span of growth, because we didn't want to go too long, we could not get 12 cycles of therapy. So our thought was, well, that's great as a concept. Could we come up with another way of giving them NK cells, and maybe an NK cell that maybe even works even better? So we know we have wide variation. The concept of the off-the-shelf NK cells came around, and that you can imagine that there's a potential increased efficacy because you can choose the donor. You can say, I want the best NK cell around that does the best work. You can have a little more predictable yield because we haven't given those patients chemo, and it will be available. If it's off the shelf, I could use it tomorrow. And of course, there could be some decreased cost because you could just do one batch, grow a whole bunch. That's pretty. So we came up with this idea of having this universal donor cell bank. These are what I call educated and smart, the best kind of NK cells. So they, a couple things have happened with these NK cells. They're selected to have an enhanced activity. So some patients have the right kind of NK cells. We're all born with different kinds of NK cells, and it's just in our genetic makeup. And you can actually decide, there's a subpopulation that has exactly the best that we think is the best. And that includes something called HLA genotype. There's a KIR genotype. And then we like them to have had a CMV infection again, because that makes them, their NK cells have certain properties that we like. And so and then you take those, and then they're what we call educated, because they're being grown with this, what's called TGF imprinting, TGF beta imprinting. And that's what happens is that you're taking these cells and growing them in an environment that's similar to what neuroblastoma does. Neuroblastoma immunosuppresses the environment, and so if you grow them in this environment, they actually can get smarter. And so that's how the process works. This all happens in Dr. Lee's lab or in the institute there. So this trial's not yet open, although we'll be opening in the next few months. The trial involves immunotherapy. So we have dinutuximab, which is what we did with the NK cells trial, the 1301. But we're adding chemotherapy to this because since the first study and current, we know that chemoimmunotherapy is very helpful in neuroblastoma. And instead of just depending on our NK cells on their own, we're adding the immunotherapy plus chemotherapy. And then at the end of your standard chemoimmunotherapy that patients get, we're giving them the NK cells. The reason it's on day 8 is because we're trying to give it not on the weekend. If you think about if any of you has had chemoimmunotherapy, usually you're getting that the week prior. It makes it a little challenging to give NK cells on the weekend. But we have, a long half-life, so that should work pretty well, and we have our GM-CSF like we do normal chemoimmunotherapy. So that trial is coming your way soon. I am going to veer off into these two trials that are NANT affiliated but not run by NANT. They're the PET-CITN trials. And the reason I'm bringing them up is because they're both based on some of the preclinical data that occurred in the laboratories of NANT, at the NANT consortium affiliated. And they are now being run through the PET-CITN network because they are also involving osteosarcoma patients and not just neuroblastoma. One of the other ways you can potentially improve antibody killing is by tinkering with this CD47, because CD47 is on the tumor cells, and there's literally, believe it or not, there's a eat me and don't eat me switch in macrophages, which are the cells that come and kill cancer cells, and you need this interaction. And if you can interfere with that interaction, you'll have more killing of cancer cells. This actually was done in Dr. Meshner's lab and at Stanford, a lot of his work. And mice question, close your eyes if you don't like mice pictures. This is a very big experiment, but it's just to show you there's a control, there's one that's just antibody right there, one with CD47, the anti-CD47, and we have the combination. The less color, the better. Obviously, you can see curing mice, it's being done pretty well. We'll have to see how well we can do that to patients. So the trial's ongoing, and it's pretty early on. There have been some interesting new data on there in terms of some toxicities that we're trying to understand. It's pretty early, but we will, I think this is a very exciting concept, and we'll learn quite a lot in terms of how we will give this and whether we can activate this other mechanism of action in immunotherapy. And no talk about immunotherapy is complete without CAR T cells, because if you type on Google CAR T immunotherapy, the first thing that will come up is usually CAR T cells, because that's what people think about. But these are really, that picture is not to memorize. I don't know it all. It's just to show you that you can potentially target the neuroblastoma all kinds of ways. One of the ways is to look at these couple different things. They're GD2, B7H3, et cetera. Mainly CAR T cells are genetically engineered T cells that are going to help you, again, get to tumor cell kill. That's really what it is, but you're really manipulating them. We talked about NK cells, now we're talking about T cells. Can you take the patient's T cells, play with them, change them, engineer them so that they can come back and actually kill cells? So there's an actual trial that's opening, not yet, but it's very, very close, for what's called the GD2 CAR T cell. So it's gonna bind to the GD2 like the dinutuximab does. Dinutuximab is an antibody to GD2. This is a CAR T to GD2. But it will be given just like you talked about before. Anytime you're giving CAR T cells, you do have to give some immunosuppression to allow for the new T cells to sit in instead of your old T cells. So there's a little bit of chemotherapy with it, but it's not high-dose chemo. I don't remember who asked that question earlier today, but that is there. So that trial is something just for people for on their radar. NANT is not running this trial, but it is affiliated, and some of the correlative study data will be coming through to understand. So, but I'm going to switch gear so we did molecular vulnerabilities in a way, very broadly. We did immunotherapy, and now I'm going to switch to MIBG, because what talk about neuroblastoma is without MIBG. We know that, we have the perfect disease, right, for targeted therapy, because it's just lights up. And so if you can use this and give it therapeutically, that would be wonderful. There have been studies over studies over studies showing that MIBG helps. The question is, how do you do it best? When do you do it? And what's the right time? And what to give it with? I will show you. So there have been single agent trials, there have been compassionate access trials, there have been feasibility trials and combination therapy trials, and many of them NANT has been involved in over the years. And and of course, you have already heard that MIBG is in the upfront setting now in a randomized fashion. Great. But we need to always think about what's next, right? How do we give MIBG? We're giving it in the upfront setting on its own, perfectly reasonable in that setting, but in our relapse refractory setting, is that the best way? Is there a better way? Can we improve our response? So there was a trial that was chaired by Dr. Du Bois that enrolled 114 neuroblastoma patients, believe it or not. That's a big number for neuroblastoma, because we generally do smaller trials. But the reason it was this many patients is because we were randomizing 3 arms: MIBG alone, MIBG with irinotecan and vincristine, and MIBG with vorinostat. Why did we choose those 2 arms? It's because there was actually data that they're radiosensitizers, meaning sensitizing, making your radiation work better, and also because we had already done phase 1 trials on each of those arms. And at some point, once you do enough trials, you need to really definitively randomize against each other, because my opinion doesn't matter. What really matters is data. And that, you need to randomize to really get data. And so here we are. We looked at the different arms. So the monotherapy, vincristine, irinotecan, and vorinostat, again, in a very strict response criteria method. Our response rate, you can see what you can take from that is really the vorinostat arm was superior to the other arm. So MIBG alone was inferior to the one with vorinostat, and the same thing with the vincristine irinotecan. It was surprising but exciting for us, because we had a lot of preclinical data that said that vorinostat may actually be very helpful. So we've taken that back a little bit and tried to think, so where do we go next? During this time period, we were also looking at whether we can add MIBG and combine it with dinutuximab. And why? Because MIBG, these are both agents that are used in neuroblastoma, and they have slightly differential response, one more for bone marrow, one more for bone, perhaps. And there's this abscopal effect that we talked about, which is, you could potentially treat one site with radiation and the other site can get more sensitive, et cetera. So we have been doing this trial where we're combining MIBG. You get MIBG, you clear your radiation, then you get 2 courses, essentially, of dinutuximab, and then you get your disease evaluation. So normally when you do MIBG, you do that and then you wait. In this case, we've added these things because we know there's a possibility that it might be better than MIBG alone. And so we've done this study. Toxicity profile has been looking great. This was also presented at ASCO. And now we're at a point where we know that we can then we have seen that MIBG with dinutuximab is safe to give. We know that the vorinostat data is sitting out there with us, where MIBG vorinostat was better than the other arms. So we decided to add vorinostat to MIBG. So now we have MIBG, if I haven't lost anyone, we have MIBG, dinutuximab, and vorinostat being added all together. And again, toxicity has been amazing for this in terms of what we are seeing so far. So what do we do there? That's great. We now have a lot of this data. we need to understand again which one is better. We have our winner, MIBG with vorinostat. We already know that. Now we need to ask, does dinutuximab add to MIBG? Does MIBG, dinutuximab, and vorinostat together, is that better than the other arms? Again, it's not opinions. It's based on, we've done a lot of the data, but just the mouse data is not going to be what we can go with. We really need to see in our neuroblastoma patients which one works better. You do have to be a little bit careful so that you're not selecting patients in different arms, different ways, so that one arm looks better just by chance because you selected quote-unquote good relapse neuroblastoma patients. So we are looking at kids with bigger sized tumors to be in equally arms and make amplified patients to be in different arms so that we can easily be able to tell that. Again, this study will open in a few months. So these two studies, the antibody off-the-shelf NK and then this one are the two studies that you should be hearing about coming up in the next couple months. Okay, imaging. Okay, we've done all these clinical trials. We're talking about clinical trials. What about imaging? Should we do anything there? We know MIBG imaging has improved, right? I don't know if you all know, but I don't know, 10, 15 years ago, more a little, it was like instead of it was much worse. And we've really, really improved in the last bit. And the question is, can we improve more? Actually, there was some really beautiful data. This is one collaboration with Sloan Kettering that has been a fun collaboration where this compound MFPG, which is a PET imaging agent, similar to properties of MIBG. And there was preliminary data that suggests that MFPG may be superior resolution and may allow better image quantification. And there are advantages, not just because it might be prettier, but because the scan is one day. You don't have to come back the next day. And it's a faster scan. And you don't need the thyroid shielding. So there are advantages, even if it was exactly the same. We have embarked on this study. This is data actually from the earlier studies where, comparison of a patient with MIBG versus MFBG, you can see more. Everyone will ask, so what does it mean if you see more? We don't know. That's what we're going to have to learn over time. Does it matter if I see more? I don't know. We're going to have to learn that systematically. But I think all of us as physicians, patients, want to know as much as we can. So this is one of those things that we're embarking on, and it's open in many sites. We have to now first learn how to use it, and later on my hope is that we'll incorporate that in upfront settings or in some of our other neuroblastoma studies so we can really understand what is the response, what does it mean. Too many things to think about. So some of the work related to that is, of course, response criteria. If you're doing imaging studies, you have to understand how do you assess response. And is response just on scans? I think a gentleman asked this earlier. Is response just on scans, or do we also look at the blood markers? Do we look at DNA? Do we look at RNA? It's all these combinations and things that we are working on currently to try and understand how to move this forward. And of course, back to the lab, we have established this relapse refractory tumors bank, but it's really open to other investigators across, so it doesn't have to be NANT investigators who can request these samples so that we can, again, inform therapies and have been looking at these mutations and tumor evolution and the immune landscape in neuroblastoma, because you can't study just neuroblastoma immunotherapy if you're not studying what's happening in the immune landscape in the patient. And finally, this to just give you an idea, for example, this is a study that we completed recently. It's called the Precision Study, where we did take patients and say, if I biopsy your bone, how successful will I be? You know, a lot of people who have this tiny ditzel and they can't get a sample because it's too small. Really trying to understand when is it successful, when is it not, and when can you get data, and when you do get data, what do you do with that data? When is it helpful and when is it not? And so there's a lot of work that's going on there that, again, should be coming out soon. Once I think all that work comes out, I think the question is, how do we take this in our next step, which would be potentially saying, I know that if you have this, therefore you need this therapy. We are not there yet. I think a lot of people have, we know ALK mutations and ALK inhibitor. That's fairly easy. But if I tell you you have a lot of macrophages in your tumor, what does that mean? Does that mean you should get dinutuximab or not? What is that? And so those are the questions that we're trying to answer. And ultimately, of course, this is a big group of people that work together. There's obviously an executive committee, statisticians, operations, our parent advisory committee, patient families, and our DSMB. And of course, we have a lot of collaborators, which are all our fun friends, our foundation, as well as our pharmaceutical partners. That is all I had for that, but I'm not going to leave this talk without sort of remembering Bob Seeger. And the reason I bring up Bob Seeger is because it's really, on June 4th, he passed away this year at the age of 82. And the reason I bring him up is not just because he has been a mentor to me, but really because he came up with the concept of this really very collaborative work that we continue on. He led the program Project Grant that focused on neuroblastoma and this concept of bench to bedside that hopefully has helped many and continues to make progress for our patients. And of course, the legacy of clinical and basic scientists who he has mentored. And I think a good friend of Pat's. And then lastly, of course, it's all about collaboration, which is what he all taught us to do. Thank you.
Thank you. Does anyone have any questions? Jennifer.
I saw you writing notes earlier.
So one of the reasons why, thank you, Doctor, by the way, for your presentation. It's great. So my son is actually on the NANT 2015-2 lorlatinib trial, and I'm very excited to read the publication that you're going to be coming out within the next year. I was just wondering if at this time, do you have any preliminary information about the rate of relapse on the medication?
The response rate that I gave you, obviously, that gives you an idea of, eventually the rate of, so these are the kids who are the CR, PR, and MR, right? But there's still another population of kids who maybe are still benefiting, but maybe didn't go to that number. So if you look at that number, it's higher than that number. I just need to go back and give you that exact number. Okay. One of the ways to look at that is doing exactly what we talked about, which is looking at how long some patients are on the therapy. I don't know how long your son is on, but for many of the patients who responded beautifully, they've been able to stay on for quite a significant number.
He's been on for a little while now, so I'm just curious. Thank you so much.
Anyone else? Okay, go ahead. Yeah, because we're going to have to wrap it up real soon.
Quick question. What's the benefit of a combination of chemotherapy and immunotherapy versus just immunotherapy?
Okay, so good question. So the ANBL 0032 was a study that looked at immunotherapy in the maintenance setting for patients who had no disease or very limited disease. There was another study called the ANBL 1221, which combined the chemotherapy with immunotherapy. That was initially given for patients with relapse refractory disease. And it has a much higher response rate than, if you take immunotherapy alone. In fact, it's in the bone and bone marrow, the response is phenomenal in that space. So there's a major advantage. The question is there a major advantage to chemoimmunotherapy in the upfront setting? And I think we have some hints of some studies that we are doing that you heard about from COG, et cetera. For example, I'm leading a study in the maintenance setting where we're adding that, but that data, we need to study a lot more to know whether adding more chemotherapy in the different time periods are helpful.
Thank you. But what is the assumption on why does that, will that benefit more?
Very good. So we do not understand exactly why when you give chemotherapy with immunotherapy that it actually works better. And it's, there's a lot of possibilities. Part of what we think may be happening is we may be inhibiting certain negative inhibitory factors. So it's like negative times negative is positive. Is somehow, we actually were not sure that when you were going to give chemotherapy that was going to reduce the immune cells, that somehow you could get a good response. But I think it's probably because you're reducing the cells that are giving immunosuppression, probably, or activating some other cells that we don't know about. The question, though, is we know that it helps in the relapse refractory space. The question is does that translate to the upfront patients? And that still, needs further investigation.
Okay, just one last question, then we have to move on.
Hi.
Hi.
My daughter had immunotherapy, and it was pretty rough on her. Do you guys track the kids that have had that and the outcomes and the difficulties that they have taken it? Because at first, her blood pressure was through the roof, and they had to transfer her to into the ICU very quickly because she dropped pretty quick as far as her vital signs and everything after not even having to take it after an hour. So it was not an option, so they say, not to take this particular therapy. So every time going forward, we had to do it completely in the ICU with the monitoring her blood pressure into her arteries, putting, monitors into her actual arteries to monitor it well. But then after it was bringing it so high, then it dropped it so low. And then it never got back to being normal. So right now, if they take her blood pressure, it's always low.
So, yes, absolutely. There are lots of monitoring of toxicity data overall for all these studies. The different immunotherapies have a different, what we call toxicity profile. The reality is I'm fortunate enough to have enough gray hair to be around from when we were doing the early immunotherapy trials to now. I think a lot of it has to do with experience and knowing the patient and what they need. There's a lot of changes that have occurred over time in making immunotherapy really tolerable. I have to say, I have not had a single patient go to the ICU with dinutuximab in, I don't know, many years, but that really requires just a lot of experience and really good monitoring of patients. But in our clinical trials, that data is very robust, clearly, because you need to do that so you can understand not only what the toxicity is on its own, especially when you're combining it with other things. There are different immunotherapies. We talked about naxitamab at some point that has a different profile, and each one, they're all GD2 antibodies, and they have their own toxicities, and but the key is to know how to give it, right? And really, there are some rare patients who clearly can't tolerate it, but overall, it's all about giving it the right way, at the right speed, in the right environment.
So it's not
Okay.
like a flat way you can give it? Because I know after she plateaued, they slowed it down some. So
Yeah.
it's not a given way that they're supposed to give it, or at a certain speed, it's just up to whoever gives it to you?
No, there are certain speeds, and also looking at how the patient tolerates it, how they're doing and reacting to how the patient, but I do feel that, generally it is, there's a happy medium for all immunotherapy to give in to the patient. It's just figuring out what that patient truly needs. So there are some parameters, but then you have to adjust to what the patient really absolutely needs and what their body does.
Okay. Thank you, Dr. Marachelian. We're going to take actually a short 5 to 10 minute break. There's some